So this is going to be revision for you guys when we look at the anatomy and physiology. So we can go through this relatively quickly. Now, we're looking at the chest because that's where we're going to be concentrating or studies. So the chest, there are bony structures that make up the chest. Sometimes we refer to it as the chest cage. You have the manubrium in the front. The body of the sternum, okay, is a continuation of the manubrium. Then you have the xiphoid process, which is the terminal portion of the sternum. You have the clavicles on the sides and the ribs on the sides further down. You have your supraclavicular fossa. And we mentioned these fossa because these areas are areas of interest in echo. We put our probes there to get images. So you need to know where the supraclavicular fossa is located and the suprasternal notch. So at the top of the manubrium, there is a little indentation there, and that's your suprasternal notch. Very popular site for doing putting your probe and getting image. So okay, so continue with the bony landmarks. Okay, so the clavicle on the side of the chest cage. Okay, and then you have the manubrium, which is the uppermost portion of the sternum. Then you have the sternal. That's the manubrium. Okay, where's this thing? Okay, then the body of the sternum. And the xiphoid process is the terminal portion of the sternal apparatus. Then we have the ribs and right and left ribs. The important thing for people doing echo is the what we call the intercostal spaces. So the intercostal spaces is the space between the ribs. So we call the ribs costal. So the intercostal spaces, there's a space between the ribs. And it's very important in echo because we usually talk about putting the probe in a certain intercostal space. So the first intercostal space is the space between the first and the second rib. The second intercostal space is between the second and the third rib, and the third intercostal space is between the third and the fourth rib, and the fourth is between the fourth and the fifth rib. So it's a basic. So if we say put the probe in the fourth intercostal space, you should have an idea where to put the probe. So the first rib is right there. The first intercostal space is just below that. That's between the first and the second rib. Then you have your second rib. The second intercostal space is between the second and third rib. Third rib right there. Fourth intercostal space. Sorry, the fourth rib. The third intercostal space is between the third and the fourth rib. And you have the fifth rib. The fourth intercostal space is between the fourth and the fifth rib. So as landmarks, when you're doing echo, we refer to the intercostal space. So you have to be familiar with the intercostal space so you can put your probe and get your image. We also talk about supraclavicular fossa and suprasternal notch. So if you were to just extend the head a little bit, this area right here, so this is your clavicle, and just above the clavicle, this area is what we call the supraclavicular fossa. And then if you come into the anterior chest, just above the manubrium, this little area, we call it your jugular notch, but that's a suprasternal notch. Okay, so jugular notch or suprasternal notch. Now, so those are the bony structure of the heart. You don't need to know anything more because, you know, we image in the heart, and the reason why we look at those structures because they prevent us from getting to the heart. So we need to know those structures. Now, when we look at the soft tissues in the chest, you have the heart, of course, and then the lungs on both sides. But you have a bunch of blood vessels in between, and you need to know those as well. All right. So need to know a little bit about the heart because that's the organ we're going to image. So the heart is a muscular pump, and you know we ascribe all sort of stuff to the heart, but essentially it's just a pump. It's a pump, a very essential pump, but it's a pump. It's located in more towards the left side of the chest, and the weight is about 250 to 350 grams. Okay, and then so this is it's a busier slide which shows the surface of the heart. So we sort of approach it in systematic fashion. The inferior vena cava comes from below, and the superior vena cava comes from above, and both vena cavae drains into the right atrium. So the right atrium is someplace right there. So it drains into the right atrium. Let's stick to the surface of the heart. So we talk about the ascendant aorta. So the aorta ascends from the heart. Okay, you know, you have the aortic valve and something we call the aortic root. You'll get used to that. But the aorta ascends from the heart. So this is the ascendant aorta. And there's outpouching, which we call sinus of Valsalva. Now, the sinus of Valsalva gives off the different coronary arteries. And on the right side, you have the right coronary artery, which comes from the right coronary sinus. So this is the right coronary artery in the surface of the heart. And then you're going to get branches of the right coronary artery. But this right coronary artery comes out of the right coronary sinus. Then there's a left coronary sinus over here, which gives rise to a blood vessel on the surface of the heart we call the left main. So the left main coronary artery comes from the left coronary sinus, and it splits to give what we call a left anterior descending coronary artery, which runs in the front, and a left circumflex, which sort of loops around the back. So if you look at the surface of the heart, you will see the right coronary artery, which comes from the right coronary cusp, and you will see the left main, which splits to give you the left anterior descending coronary artery and the left circumflex. They're all on the surface of the heart. Most of the anterior aspect of the heart is occupied by the right ventricle, however. So most of this area here is the right ventricle. The left ventricle is over this side. The left atrium receives 4 pulmonary veins. So the left atrium receives 4 pulmonary veins. So pulmonary veins are veins which drains oxygenated blood from the lungs. Okay, so this is one of your pulmonary vein there, and then this is another, and then so there are 4 of them in total. You have 2 on the left side. You have an upper and a lower, and then the same thing on the right. You have an upper and a lower. But all 4 pulmonary veins drain into the left atrium. Okay, and you can see it right there. Okay, so we talk about the inferior vena cava, which comes from below, superior vena cava, which comes from above, and drains into the right atrium. Now, leaving out of or when you get into the right ventricle, blood leaves from the right ventricle through the pulmonary trunk. So this is what your pulmonary trunk looks like. And the reason why it's color-coded blue is because it's carrying deoxygenated blood. Okay, so we depict that sort of blue. So this pulmonary trunk arises from the right ventricle. So it takes deoxygenated blood from the right ventricle, and then the pulmonary trunk splits to give you a right pulmonary artery, a right main pulmonary artery, and a left pulmonary artery. And they're going to go to the respective lungs. So this is deoxygenated blood on the right side of the heart, and that blood is going to travel to the lungs to be oxygenated. And then when the blood is oxygenated now, so it's full with oxygen, it's going to travel via the pulmonary veins to the right atrium. So quickly, that's what it looks like. Now the heart, even though we just put the heart out there, the heart is covered. There is a epicardium. Okay, so there is well, first there is a pericardium. So there's a pericardium. The heart is in a sac. Okay, so if you're going to do any type of surgical procedure to the heart, you have to open the pericardium to get to the heart. The heart is not just lying there in the chest. It's in a like a bag. If you want to say the heart is in a bag. So when you open the chest, you have to get to the heart to do anything. You have to open the pericardium. Pericardium covers the heart, and there is two layers to the pericardium. There's an outer fibrous pericardium and an inner serous pericardium. So the inner serous pericardium also has two layers. The outer is the parietal and the inner is the visceral. So the heart is in a bag, and if you were to observe any type of cardiac surgery, you'll realize that, open the chest and you get there, you have to open the pericardium now. Okay? Again, there's the outer fibrous pericardium, and then there's an inner serous pericardium. Inner serous, you have two layers, the parietal and the visceral. The visceral is essentially on the surface of the heart. So if you were to highlight it, it looks something like this. Okay, so again, this is the left ventricle over here, right ventricle right there, and then this is the sac that the heart is uh, enclosed in. So the fibrous pericardium is outside of these layers, but just below the fibrous pericardium, you have the parietal pericardium, and below that, you have the visceral pericardium. The visceral is actually on the surface of the heart. So, and the reason why you need to know about the pericardium is because you're going to see a lot of pericardial effusion. So, having an idea, where this fluid is located is important. So again, the serous pericardium is divided into outer parietal pericardium that is fused with the fibrous pericardium. Then you have an inner visceral pericardium, which is part of the epicardium. So after you leave the pericardium now, then directly on the surface of the heart, there's an outer layer we call the epicardium. So it's the outer layer of the heart wall. That's the epicardium. Then you move from the epicardium, you're going to get to the muscle. You get to the muscles of the heart. And the muscle of the heart we call the myocardium. So myo means muscle, cardia means heart. So all right, so the myocardium is the muscular wall of the heart. Okay. Then when you get to the inside, when you get to the actual inside of the heart now, so if you move from outside in, we talk about the pericardium, then the epicardium, then the myocardium, which is the muscular layer, and then the inner surface of the heart is the endocardium. The endocardium is in direct contact with blood, so it has to be smooth It's not a rough surface. Okay. So if you were to do a cross section of the heart, if you were to cut the heart, in two, in a vertical fashion, then if you look at the right side, so this is the right side of the heart and the right ventricle, the right ventricle, if you actually get a chance to look at it, it's rough. It's not as smooth as the left ventricle. So it's a much rougher but again, the outer portion would be the pericardium. Then you get to the epicardium. This is the myocardium, which is the muscle. Then the inner surface of the heart we call the endocardium. These little humps are the papillary muscles. So these are papillary muscles that are inside the heart. On the left side, you have two papillary muscles. And in the right ventricle, you actually have three papillary muscles. And these papillary muscles are attached to coordinate tendons. These little fine thread-like structures which attach to the valves. So the coordinate tendons which attach to the papillary muscles and attach to the valve prevents eversion of the valve. So if these papillary muscles are ruptured, then the valve is just going to flap right into the atrium. Okay. All right. So again, one of the things they can use to identify the right ventricle as opposed to the left ventricle is the number of papillary muscles, usually 3 papillary muscles, where the left ventricle have 2. Again, the right ventricle tends to have a rough interior. There's a lot of trabeculation, which makes it rough. Okay, so the right atrium is on top, and there are orifices in the right atrium because the superior vena cava drains into the right atrium. The inferior vena cava also drains into the right atrium. So there are 2 orifices. Okay, there. So this is the right atrium. Then you have your tricuspid valve right there. Tricuspid because there are 3 cusps or 3 leaflets. Okay, and then the right atrium. The blood from the right atrium is going to drain through the tricuspid valve into the right ventricle. Then the blood is going to leave the right ventricle through the pulmonary trunk. Right here, you're going to have the pulmonary valve. The pulmonary valve is right there. And the blood is going to go through the pulmonary trunk. Then you have the right pulmonary artery and the left pulmonary artery. This is your interventricular septum. Okay, the interatrial septum is right up there. Okay, so this is the left ventricle. Again, it's not as rough as the right ventricle. You can see there are 2 papillary muscles, the coordinate tendinae, which attach to the mitral valve. The left atrium is right there. Remember what we said, 4 pulmonary veins drain into the left atrium. On the left side, you have an upper and a lower. And on the right side, you have an upper and a lower. Okay. So so this is the left ventricle. The aortic valve is someplace right there. Then the aortic valve, from the aortic valve, you're going to have what we call the aortic root, and then the ascending aorta. So this is a portion of the ascending aorta. Then the aorta comes up and it arch, so we call this the aortic arch, and then these are what we call arch vessels. This is the innominate artery. The innominate artery splits to give you the right subclavian and the common carotid, right? Common carotid. This is the left common carotid, and this is your left subclavian. You need to know the branch vessels from the aortic arch and the name of those structures. So if we quickly look at the anatomy of the heart. So the right atrium receives blood from the inferior vena cava and the superior vena cava. The tricuspid valve, which is located between the right atrium and the right ventricle, there are three leaflets. There's a septal leaflet, an anterior leaflet, and a posterior leaflet. And when we do echoes, we'll actually see these leaflets and we can name them. One of the things that you need to do once you start echo, you need to know where the right ventricle is located. And once you can do that, then you can start identifying congenital heart disease. Always tell the technicians and the junior doctors that when you scan in a heart, a patient comes to the lab, the structures are not labeled. The structures are not labeled in the chest. So you have to determine what you're looking at. So by knowing the anatomy and knowing what the different structures should look like, you can put the pieces of the puzzles together. Now, a fact is that the tricuspid valve is usually located lower in the ventricle than the mitral valve. That statement is very important, so you need to file that statement place and fully understand what it means. It means that when you look at a heart on echo, the valve that is lowermost in the ventricle is the tricuspid valve, and that's going to identify the right ventricle. We'll go over that more. The coronary sinus is a vein that empties blood in the right atrium. It runs in the groove between the left atrium and the left ventricle on the posterior surface of the heart. And then the right ventricle receives blood from the right atrium through the tricuspid valve. The blood leaves the right ventricle through the right ventricular outflow tract, and in echo we identify these tracts. Right ventricular outflow tract, left ventricular outflow tract. You have to have a good understanding where these structures are. So the blood leaves the right ventricle through the right ventricular outflow tract and through the pulmonary valves into the main pulmonary trunk and then the right and left pulmonary artery. Then the pulmonary circulation, deoxygenated blood, which leaves the right ventricle, is going to travel through the pulmonary valves into the pulmonary trunk that we discussed before. The pulmonary trunk is going to branch into two pulmonary arteries, a left and a right, which delivers deoxygenated blood to the corresponding lungs. So this is blood that is devoid of oxygen somewhat and needs to get oxygen. So the blood travels to the lung where it's oxygenated. So if you want to put it in a cartoon fashion, it looks like this. So the right side we put in sort of blue to denote that it's deoxygenated blood we're talking about. Inferior vena cava from below, superior vena cava from above. They both drain into the right atrium, and the blood is blue. The blood is going to flow across the tricuspid valve into the right ventricle. Then still deoxygenated blood is going to flow through the pulmonary valve, pulmonary trunk, right and left pulmonary arteries. So it's going to go to the lungs. So these are lungs. So the blood is now going to be oxygenated in the lungs. So the color changed from blue to bright red. You have this nice bright red blood flowing in the pulmonary veins. On the right side, you have two, a upper and a lower. On the left side from the left lung, you also have two. You have an upper and a lower, and all four pulmonary veins drain into the left atrium. And then the blood is going to flow from the left atrium across the mitral valve into the left ventricle. Then the blood is going to leave from the left ventricle. So again, nice, rich, oxygenated blood is going to leave from the left ventricle. It's going to travel through the aortic valve into the aortic root, ascending aorta, and then to the aortic arch and descending aorta. So that's it. Again, so the pulmonary veins carry oxygenated blood from the lungs to the left atrium. There are 4 pulmonary veins, and the reason why I was stressing this is because if a patient is going for pulmonary vein isolation, so that's a technique where we treat atrial fibrillation. So patient with atrial fibrillation, we do pulmonary vein isolation. You have to identify all 4 pulmonary veins. So they're going to send the patient to the echo lab and say, you identify the 4 pulmonary veins. So in the echo lab, you have to identify them. You have congenital situation where sometimes, the pulmonary veins are not where they're supposed to be located. So you have to know how to find them. So anyway, so there are 2 pulmonary veins on the right side and 2 on the left side, the upper and lower. So again, cartoon looking at the inside of the heart. So inferior vena cava, superior vena cava drains into the right atrium. You have a atrial septum someplace there. This is your tricuspid valve, attached via coordinate tendinate to papillary muscles. This is your right ventricle, it's fairly rough surface because of all the trabeculation. This area is what we call the right ventricular outflow tract, right ventricular outflow tract, just before you get to the pulmonary valve, just before you get to the pulmonary valves. Then the pulmonary valves, pulmonary trunk, then you have a right pulmonary artery, left pulmonary artery. They're going to go to the respective lungs. Okay, the blood is oxygenated, then it's going to flow through the pulmonary veins to the left atrium. Okay, going to flow across the mitral valve into the left ventricle. Okay, so you can see the mitral valve. The mitral valve has 2 leaflets, an anterior and a posterior, whereas the tricuspid has 3. The mitral valve has 2. Mitral valve anterior and a posterior. You can see the coordinate tendinae and the papillary muscles right there. Okay. Blood is going to leave from the left ventricle, across the aortic valve into the aorta. So again, looking at the pulmonary circuit, so superior vena cava, inferior vena cava, right atrium, right ventricle, your right ventricular flow tract is right there. This is your pulmonary trunk. This is the right pulmonary artery, left pulmonary artery, and then the left side of the heart gonna receive oxygenated blood. Then once the blood is oxygenated in the lungs, it's going to travel via the pulmonary veins into the left atrium. Okay, 4 pulmonary veins again. Okay, traveling to the left atrium, then from the left atrium to the left ventricle. Then from the left ventricle, it's going to travel through, cross the aortic valve into the ascending aorta and down the aorta. So there's a cartoon to further elucidate that. So the left atrium is going to receive oxygenated blood from the pulmonary veins. The mitral valve, which is located between the left atrium and the left ventricle, have 2 leaflets. You have an anterior and posterior leaflet. So mitral valve, 2 leaflets, anterior and posterior. Very important because in echo, you have to look at them. You have to identify them. You have to see what they're doing. So, echo looks at the heart and it looks at the function of the heart. And you have to determine if things are normal. Is the mitral valve normal? Is the mitral valve opening and closing okay? Is there a tear in the mitral valve? Is the papillary muscle ruptured? So there's a lot of stuff that the echo will allow you to look at. So remember what we said, the tricuspid valve is located lower in the ventricle than the mitral valve. So therefore the mitral valve is usually higher in the ventricle than the tricuspid valve. To identify the right side of the heart, the valve that's located the lowest in the ventricle, that is the tricuspid, and that's the right ventricle that it's allowing blood to flow into. So the papillary muscles, papillary muscles in the right ventricle and the left ventricle. In the left ventricle, there are two papillary muscles, and you need to know the name of those papillary muscles. There's an anterior lateral and a posterior medial, and later in the course you'll understand the significance of these papillary muscles. Okay, very important. But they're in the left ventricle, there's an anterior lateral and a posterior medial. They attach to the mitral valve via the chordinae tendineae, and when they contract, they prevent inversion or prolapse of the valve. The left ventricle is going to receive oxygenated blood from the left atrium through the mitral valve. The blood is going to travel now from the left ventricle through the left ventricular outflow tract and across the aortic valve into the aorta. So another important thing that we do in echo, we look at the aortic valve, because the aortic valve get disease fairly often. So we look at the aortic valve, we look at what we call the aortic root, we look at the ascending aorta, we look at the heart and descending aorta. So the aorta or the aortic valve, oxygenated blood leaves the left ventricle through the aortic valve. So the oxygenated blood in the left ventricle is going to pass across the aortic valve into the aorta. When you look at the aortic valve, there are three leaflets. There are three leaflets or cusp. There's a left, there's a right, and there's a non-coronary. It's very important to identify those. So in echo, we usually identify the different leaflets or cusp. Remember, one of the things that we said when we started the anatomy, we said that the left cusp gives off the left main coronary artery, and that left main coronary artery is going to divide into a left anterior descending coronary artery and a left circumflex. The right cusp is going to give off the right coronary artery. The non-coronary cusp doesn't give off any coronary artery, and hence the name non-coronary cusp. It does not give off any coronary artery. Okay, that's why it's named that. Okay. Again, the aortic valve, three cusp or leaflets, and so this is the cusp. Okay, and leaflet when it opens in systole, closing diastole. Okay. Okay, so if you were to look at the pathology, so again, the left cusp, which the left main coronary artery is going to come out of that, and then the right cusp, the right coronary artery is going to come out of that. Non-coronary doesn't have any coronary. So let's look at the aorta now. So the aorta is a large blood vessel that carry oxygenated blood from the left ventricle to the head, neck, thorax, and limbs. The aorta carry oxygenated blood. It delivers oxygenated blood throughout the whole body. Okay, it's divided into an ascending aorta. You get the aortic arch and the descending aorta. There's also an abdominal aorta because we just doing the thorax. We don't mention that too much. So if you were to separate the aorta from the body, aortic valve will be right down here. And these are the coronary arteries coming off the coronary cusp. So this would be the right coronary artery, comes from the right coronary cusp. The left coronary cusp, which is over here, gives rise to the left main coronary artery, which divides into a left anterior descending coronary artery and left circumflex. The non-coronary cusp is on the opposite side. No coronary artery comes off there. So this is the ascendant aorta because it ascends and then it arch. These are the arch vessels. Again, you need to know the arch vessels. This is the innominate or the brachiocephalic, as it's called in some situation. This is the right subclavian. This is the right common carotid, left common carotid, left subclavian. This is your descending aorta. Once it crosses the diaphragm, it becomes known as the abdominal aorta. And there are branches there. Okay, so what about the septum? So there are septum, we talk about the atrial septum. The atrial septum separates the right atrium and the right atria and the left atria. It separates the right and the left atria. Okay, it's relatively thin. There's a structure we call foramen ovale, which allows blood to enter the left atrium in the fetal circulation. So it has a purpose in utero, but once a baby is born, it should close. Okay, so foramen ovale, we talk about it a lot in echo, so you need to have a little understanding. The ventricular septum is a little bit thicker, and it separates the right and the left ventricle. There are different areas to the ventricular septum. We talk about a muscular septum, which is thick, and a membranous septum, which is thin, and then there's a fibrous septum. So if we were to just look at the top of the heart, so this is the right atrium, and this is left atrium. So relatively thin septum, which separates both atria. Okay, and in the right at the center there is a foramen ovale, as we mentioned, foramen ovale. So in fetal life, remember the fetus is gonna get blood supply from the placenta, the maternal placenta. Oxygenated blood is actually gonna travel to the right atrium, and then it's gonna travel through the foramen ovale into the left atrium. Because remember, the baby's lungs is not functional. The baby's lungs is not functional. All right, so that's the atrial septum. So the ventricular septum now is a much thicker structure. You have the muscular portion, which is there, and then what we call the membranous portion is right up here. So membranous portion of the septum is right there, right up there. So this is the muscular portion. Okay, and then the membranous portion is right up there. So that's the anatomy of the heart in a nutshell. So you need to know the structures of the heart and the function. So the physiology is basically how the heart works, and we're going to go through that relatively quickly. So in systole, the heart contracts. In diastole, the heart relaxes and fills. It's important to understand the physiology because a lot of what you do in echo is you do some anatomy, but a lot of it is how the heart works, physiology. So again, when we talk about systole, it's contraction of the right and the left ventricle. We're going to introduce some concept that you probably never heard before, but it's crucial, and we use these in echo. So we're going to look at the systole in detail. So when we say systole, in systole, All right, let's just look at the left side, and the same thing, that what happens on the left side also happens on the right side. In systole, the heart contracts. What that means is the heart muscle come together. Okay, it's pumping the blood out. So it's the aortic valve has to open. So in systole, the aortic valve opens and blood gushes through the aortic valve into the aorta. Okay. In systole, the mitral valve close. In systole, the mitral valve close. So let's go over all of this. In systole, the first thing to happen, the mitral valve close. Okay. But what you need to understand is that when the mitral valve close, the aortic valve doesn't open the same time. There's a little time delay. There is something we call isovolumic contraction, where the heart starts to contract. The mitral valve close. Well, the mitral valve close first. The heart starts to contract, but the aortic valve does not open yet. That period of time is what we call the isovolumic contraction time. Isovolumic because the volume is not changing, and the heart starts to tense, getting ready to fully contract. After that isovolumic contraction time, then the aortic valve opens and blood gushes out of the left ventricle across the aortic valve. Then at the end of systole, what happens? The aortic valve closed now. The mitral valve is still not open. There's a time delay. That situation, all the valves are closed. You finish systole and now you're going into diastole. That period of time is what we call the isovolumic relaxation period or time, because you're going into diastole, the aortic valve closed, the mitral valve is still closed, the mitral valve has not opened yet. So that period of time, very short, is called the IVRT, the isovolumic relaxation time. Then the mitral valve opens and blood gushes from the left atrium into the left ventricle across the mitral valve. The blood sort of travel in spurts. As soon as the mitral valve opens, there's like a suction effect where blood is pulled from the left atrium into the left ventricle, and we talk about the E velocity. Okay, so in echo we talk about the E velocity, showing you that the blood is being sucked in from the left atrium into the left ventricle. Because you have that rapid transition of blood, there's a quick equalization of the pressure between the left ventricle and the left atrium. And because you get that equalization in pressure, you have cessation of flow. There's no flow. And we refer to that as diastasis. There's no flow, diastasis. Then towards the end of diastole, then the atrium contracts. We call that atrial contraction, to force an additional amount of blood across the mitral valve into the left ventricle. That's atrial contraction. So that is how you have to approach the function of the heart. You have to look at the function of the heart in details, looking what happened in systole, what happened in diastole, because that is how, when we do echo, that's how we look at the heart. Okay, so just to go over that, in systole, the first thing that happened the mitral valve closed. The aortic valve was closed, still not open. You have IVCT, isovolumic contraction time. The heart tends to contract. Then the aortic valve opens and blood is ejected across the aortic valve. Okay. At the end of systole, the aortic valve closed. The mitral valve is still closed. You're going now into diastole, but all the valves are closed. That period of time where all the valves are closed before the mitral valve opens is called IVRT, isovolumic relaxation time or period. Once the mitral valve opens, then you have a suction of blood initially, giving rise to what we call an E velocity. Then you have rapid equalization of the pressures, giving rise to what we call a diastasis, cessation of flow, so to speak. Then towards the end of diastole, the atrium contracts and blood is forced from the atrium into the ventricle to give you the last portion of diastole. So that is how the heart works. So let's just go over that. So contraction of systole is contraction of the right and left ventricle with IVCT, isovolumic contraction time. It is the period when all the valve, tricuspid, mitral, so we lump in both right and left side. When those valves are closed before the pulmonic and the aortic valve open, all the valves are closed in IVCT. The aortic and the pulmonary valves, pulmonary valve now opens and blood is ejected from the ventricle. So if you want to just separate the right side or the same thing that happens on the right side happens on the left side. Systole, okay. So again, in systole, the mitral valve, the tricuspid valve, and the mitral valve have to close. But before these valves open, all the valves are closed and the heart starts to tense, and we call that isovolumic contraction time because it's getting ready to contract, but the valves are closed. The aortic valve on the left and the pulmonary valve on the right have not yet opened. Okay. Okay, so when we go into diastole now, the period during which the right and the left ventricle is relaxing and fills with blood after systole, the aortic and pulmonary blood. So when you're going into diastole, the aortic and the pulmonary valve close at the end of systole. The interval between the aortic and pulmonary valve closing, so when the aortic valve on the left and the pulmonary valve on the right close, the mitral valve on the left and tricuspid valve on the right have not yet opened. That period is called the IVRT, isovolumic relaxation time or period. All the valves are closed. Okay, so again in diastole, the pulmonary valve on the right, aortic valve on the left, they're closed, and the tricuspid on the right and the pulmonary and the mitral valve on the left opens. But you have to know the details of that. Okay. So when the mitral valve on the left and the tricuspid valve on the right opens, there's a rapid suction of blood from the left and the right into the ventricles, and we talk about the E velocity. So once you start doing echo, we talk a lot about E velocity because the E velocity is going to tell you how the blood is flowing. As soon as let's look at just on the left side. As soon as the mitral valve opens, is the blood flowing adequately from the left atrium into the left ventricle? Okay, then with with that rapid suction of blood from the left atrium to the left ventricle, you have an equalization of the pressure, cessation of flow, and we call that diastasis. After that, then the atria contract, the left atrium or on the left side and the right atrium side contract, add more blood to the ventricles, and we talk about the A velocity. Okay, so we talk about E and A velocity quite a bit, and they allow us to look at the heart in detail. So that's the anatomy and physiology of the heart. So you need to know the structure of the heart. You need to know how the heart functions, because when we do echo, that's exactly what we're looking at, the structure and function of the heart. Once we finish that, then we can start talking about scanning the heart.